I'd like to welcome our next speaker for today, Dr. Socia Love Thurman. And Dr. Socia Love Thurman is a citizen of the Cherokee Nation of Oklahoma and is also Yuchi in Delaware. She studied microbiology and Native American studies at the University of Oklahoma. She then attended the University of Minnesota, Duluth Medical School, and completed her family medicine training at Swedish Cherry Hill, Seattle Indian Health Board. Dr. Love Thurman now serves as the Chief Health Officer of the Seattle Indian Health Board, where she oversees health and human services. She continues to provide primary care of all ages with medical interests, specifically including women's health, including pre and postnatal care, procedural skills, point of care ultrasound, and Native health equity. Dr. Love is also appointed to the health and sanitation position on the Washington State Board of Health. And in her free time, Socia loves or enjoys exploring the Pacific Northwest with her husband and 3 young children, dancing traditional Southern buckskin at powwows, cycling and swimming, and engaging in social justice work. So I'll hand it over to you now, Dr. Love Thurman. Thank you.
Oh, Osio Nagata, Social Love Dawadoa, Chichalage, Yuchi, Ale Delaware. Thank you everybody for including me today. I'm really happy. I only wish I could have caught the talk before me. I just have loved getting to know Itai, and then seeing the work that Itai and Jericho are doing. I'm really excited to get to work together in Indian country to do what we're doing. So thanks for having me. I am excited to share a little bit about what we have going on in our urban Indian community here. And Alicia, did you want me to just share my own slides? Does that work best?
Yes. Okay. Yes, let me know.
Can
you just do presenter view?
Work?
No. Yes, so then on your display settings, then you'll change it up to. Yes, perfect. Awesome.
That look good. Okay.
Yeah.
Perfect. All right. So today I just want to share a little bit about some work that we've been doing, but a really new exciting venture that we've been on here at the Seattle Indian Health Board around birthing sovereignty. And we were fortunate to receive a HRSA grant that is going to inform a lot of the work that I'm telling you about today. So just a little bit about me. I, as you heard, am a family medicine physician in our clinic and the chief health officer. So I oversee all of our health and human services here at Seattle Indian Health Board, which is an urban Indian organization. Yeah, we are also a federally qualified health center. So we actually serve both native and non-natives in what we call the native way, which really is a great way to continue to keep traditional medicine in our practices at the forefront of all the work that we do, while being able to serve all people sort of in that way, which we really love. So today I'll just share a little bit about us, and then a little bit about our infant maternal health that we know is going on in the community that we serve, and then be able to share again sort of the things that we're doing and the things that are coming for us through our Indigenous knowledge informed systems of care, or what we would call our Indigeno model. So Seattle Indian Health Board is a community health center that provides health and human services to all of our relatives, or as we call our patients, in a culturally attuned way. Like I said, we service American Indian and Alaska Native people, and that includes all ages from birth to death care, primarily through family medicine, but we also have an array of specialty care services that we provide all people as well. And like I said, we also have lab and pharmacy, behavioral health, including treatment for substance use disorders, as well as mental health, and case management for folks facing gendered violence or housing insecurity, as well as just general case management for social work. So we have those things. I mentioned dental. And so we're really excited, I think, to get to share that we also we have another arm called the Urban Indian Health Institute, which is a national leader in policy and advocacy, as well as research. And so it's a nice combination of being able to combine the work with direct care services along with research, policy, and advocacy. And we've been around since early 1970s. In this past year, we were really excited we had one clinic and we launched 2 additional clinics. We have a clinic at Pioneer Square, which is in downtown Seattle, and it is a really beautiful collaboration with one of our community partners, Chief Seattle Club, which focuses on really taking care of our most vulnerable American Indian Alaska Native relatives who are mostly facing housing insecurity. So they built a beautiful housing complex in downtown Seattle and Pioneer Square. And we are housed in the basement of that building, providing pharmacy, medical, lab services. And it's really great for people who are in that building or nearby or in their day center, which is right next door, to be able to have ease of access to clinical services. When you've got a lot of other things going on in your life, it's nice when those barriers are really lifted and people can get in really easily for medical care that is also very culturally tuned. We also opened another clinic in Lake City, which is in North Seattle, and it is a collaboration with another community partner called the North Helpline Food Bank, and they service families from the North End. And so we're kind of right next door to them in a housing unit that it services primarily those who have been homeless in the past or have been veterans and have been able to accrue long-term housing. So we are on the 2nd floor of that housing unit. And so what I would say is a beautiful way to see how community collaborations can really work. And so we look forward to more of that in the greater Pacific Northwest area. The other thing I mentioned on here is that, 52% of our relatives are otherwise known as our patients do identify as American Indian or Alaska Native. And then 65% of our employees identify as American Indian Alaska Native. Our leadership at the health board, really, those numbers are even higher, with 80% of our executive team being AIAN, and then really focusing too on growing our LGBTQ workforce, and that's sitting at about 12%. So when we talk about BIPOC and in the workplace, I think we're really excited that we really do represent the communities that we take care of. And I think that's why we're doing such great things. So this is just a slide that is a reminder of the statistics that 76% of American Indian and Alaska Natives do live in urban areas. And so, even from the start of SIHB, it was really about people who had been moved through the Relocation Act into big cities from reservations, and essentially were in great need of medical care, medical services. And so we were created through the American Indian Women's Service League, who saw that need in our community here in Seattle and created a volunteer clinic to take care of the natives who were just coming from all over looking for opportunities in healthcare. And so we all look, you can't just look at someone and know that they're Native, right? Like, we have a beautiful mix of races and cultures. And so we're a much needed part of the ITU system of care, representing the U in that. And I think that leads into kind of where we're at on the maternal child health side. And so I think just to start, I just wanted to kind of give sort of the overarching view. I know a lot of you probably are already well versed in this, so I'm sorry if it feels like it's redundant. I don't always like to start with the statistics, but I think it is important to lay the framework of why this is so important that we're talking about this. So maternal and infant care in the United States is not doing great, or we wouldn't be here. So there are, for the community that we serve, there are only 10 Indian health services that offer obstetrical facilities. And so here in the state of Washington, we do not have an IHS facility. And so 100% of our relatives that we serve do have to have their births outside of IHS. And across Indian country, we know that over 90% of births do happen outside of IHS. So what we have realized with our own maternal child health crisis is that there needs to be more culturally attuned, more community-based organizations that can provide that appropriate service in traditional birthing, parenting practices to help support maternal and infant health. So I think we're always sort of trying to lay the framework that we know our community best. And so by redirecting those resources to institutions like ours, that we can improve this maternal child health crisis that we're seeing in Indian country. So unfortunately, in 2020, non-Hispanic AIAN mothers were nearly 3 times as likely to receive late or no prenatal care compared to non-Hispanic whites. We saw also more recently that a lot of the studies are showing that the rates of suicide, self-harm, and violence are a huge disparity that we're seeing very strongly in our American Indian Alaska Native populations. Rates of suicide went from 1.8 to 9.3% over the past decade. And also intimate partner violence was a part of 71% of maternal mortality homicides. And 45% of suicides could be linked also to that intimate partner violence. And so just another plug that if you have ability to get more funding in place to provide that really specific support that people need with gender-based violence, we need it all over Indian country, right? Because we're all seeing these pregnant people come in, and I think 1, knowing it's an issue, but 2, being able to ask in a cultural way those questions that can elicit whether someone may be at risk for violence. And then making sure that we're screening not just in the postpartum period, but that we're also screening in early pregnancy and throughout pregnancy around how people are doing from a mental health standpoint. I think that really doesn't fit necessarily with the guidelines that we get right now in maternal health, that we're screening or asking these questions on a regular basis. But I think what our studies are showing is that we should be having this open dialogue with folks when they do come in. And I think just going back to the point about American Indian Alaska Native people not getting early prenatal care, I think is kind of multimodal. We see this a lot with fear of stigma, fear of racism that people will face when they present for prenatal care. I think that anecdotally, I've seen a lot of people who have felt judged when they became pregnant, and if they wanted to continue a pregnancy, they weren't always given that guidance, but rather pushed into maybe abortion or other things, just people not feeling confident in them as parents. But I think there's a lot of reasons why people are late or don't receive prenatal care. I know I hear that another reason people don't get that is just because of lack of access. The level of prenatal care access is so variable across the country. I think one of the things we do at the health board is really try to make pregnancy or pregnancy-related concerns a priority, so that if we have someone call or walk in, we will nearly drop everything to make sure that that a pregnant person or their child gets seen. And so I think it's trying to limit those barriers to getting care as much as possible, that you just get them in the door and get them seen in a culturally attuned way. So that's the health disparity around maternal health. I wanted to also add the importance of talking about infant mortality, because it's so uniquely tied to our mamas, our birthing people, that it's just as important after they've had their baby that we continue to really monitor them closely. We did see the highest rates of infant mortality in American Indian Alaska infants, Native infants who were born preterm or low birth weight. And also in 2019, we saw that our infants were 3 times more likely to die of SIDS, or sudden infant death syndrome, than non-Hispanic white infants, which is just, it's not okay, right? I think these statistics are always really hard to sit with or even speak to. And that in 2019, we saw 1.8 times the rate of infant mortality. And so I think when we think about the health of our pregnant people, it's just as important that we talk about infant care and support of infants in that early, really vulnerable stage for both moms and babies. So I want to kind of pivot a little bit into the model of care that we focus on. In general, I would say, I'm actually going to pull to our Indigenous slide. So I'm going to just pop forward just here. So we at the Health Board, just in general, really focus on our Indigenous model, which is seen here. We focus on putting our relative or our patient there at the center, white circle in the middle. And then all the care that we do sort of wraps around that person in that unique kind of individualized way. And so each relative will be assigned to a care team that includes their primary care provider. It includes nurses, medical assistants, care coordinators who help between if they were to get an internal referral to maybe one of our specialty services, or they need an external referral to say a maternal child health OB specialist or something like that. The care coordinator is really there to kind of handhold through that process, make sure that they can get their appointments scheduled, whether it be with us or somewhere else, and work closely with our social work team to ensure that if they need a ride or some way to get to those appointments, that we're also doing that wraparound care. Our care teams also include clinical pharmacists, which can be so important, especially in maternal child health when we're thinking about someone who's newly pregnant and what medications they may be on or want to be on, that we have point of care pharmacy help available. The clinical pharmacist will also help us if we have people who are on Suboxone. All of our care providers do provide medically assisted treatment, things like Suboxone, but our clinical pharmacist can also help with those visits, and even in pregnancy, make sure that we're screening, but also getting people into care who might need things like Suboxone during pregnancy. Our care team also includes our traditional Indian medicine apprentices. These are our liaisons into our traditional Indian medicine practitioners, those care providers who can assist with different types of things people may need. You know, we take care of over 300 different tribal populations in our clinic. And so there isn't a one size fits all, and we're not trying to be sort of a one size fits all or anything like that, but we do try to connect people into some of our traditional ways of being, whether that be someone who's going through something and needs to be smudged, or needs connection to sweat lodge or other ceremonies that are important to them, but maybe unable to do that because of being away from home or being away from family. And so our TIM apprentices can sort of assess their situation and then be able to connect them into the right care. We also have behavioral health that we'd like to be, that are a part of our teams. That includes social work, counselors, substance use disorder counselors as well. And we also have registered dietitians. And in the future, we include dental as well, so that even the dentist and the medical are all connected around taking care of that relative. And then the kind of final tier around that I'll just talk briefly about is our specialty care teams that include those traditional medicine practitioners who may come in at varying times to help assist people. We also have complementary medicine, including naturopathy, acupuncture, and osteopathic manipulative therapies. We have human services. I mentioned having gender-based violence or domestic violence support. Support for those who are facing housing insecurity, substance use disorders, need help connecting. We have WIC sort of in-house and connect with that, or lactation, as well as our other specialties like podiatry, psychiatry. And we're kind of trying to grow that out a little bit too. And so I think all in all, this slide is really to show that we really try to focus care around a relative and try to meet that person has access to as many people as they need in their life to get their needs met. And so they may come in for a medical appointment with a doctor, but during that appointment, they may also meet a pharmacist, a dietitian. They may get connected to traditional medicine. And then they may be referred and have sort of that hand-holding with our care coordination to get them to the right place and feel confident in the care that they're getting. And so that's when I think about our Indigeno model, this really does look, when we're talking about maternal child health, this is sort of your usual experience. If you had a pregnant person coming in, they would expect right now that they get one-on-one care that's tailored to what they need. And then going back, I am now excited to share kind of where we're going with specifically around our maternal child health work. And so we currently, so during the over 20 years, or sorry, the over 50 years that we've been open, during about half of those, we were a pillar in the community for having lunches on a weekly basis where pregnant people and their children could come in and get to meet with other pregnant people and their children and have a meal and just kind of talk. It just created a community space, but also did allow people who came in that day to maybe get their medical appointment or see WIC or nutrition. And during the pandemic, we sort of closed everything down as we needed to. And just last week, we were able to reopen our expecting and new parent lunches. And so we have opened that up to our community, whether they receive services with us or not, that they're welcome to come in. We kind of try to keep it pretty open, like as a drop-in anytime between 11:30 and 1:30. And we cook a warm meal. Oftentimes that is really rooted in some of our traditional foods. And we then we've been creating sort of dialogue, different teaching or topics that people can discuss around the process of whether it be birthing or parenting. And we include a lot of different people available for those lunches, and it could include medical doctors, nutritionists, lactation. We're also really excited to open up the space to our community partners. You're going to hear, I think, from Cami Goldhammer, who is a wonderful community partner at Hummingbird Indigenous Family Services. And so I think her team is going to come and share about doula services and home visiting. They do a lot of work with lactation and peer support. And so we're really excited to open up the space again to the community. And it sort of leads into a lot of the work that we're hoping to do in the future with the grant that we just got. And so we're excited that this lunch up came back last week. It was really exciting to launch it again. And we had actually just one person show up, but it was one of the most enriching conversations I'd had. Just for me, I was able to join for the meeting, and we opened it up with just our intentions for what we would like, what the community wants and needs. But then also we talked a lot about about like your birthing experience and if there were any ceremonies that you felt comfortable sharing that were a part of your pregnancy or your postpartum period. And so just with that one question, I think it opened up a whole beautiful conversation from folks to be able to just share, whether it be they hadn't had a lot of experience knowing some of the traditional ways in pregnancy, or they did and they were able to either have the ceremonies like they had been taught, or they were able to modify it just based on maybe not being home or not having exactly everything right, but being able to create ceremony, even if there were modifications or things that were slightly different. And so it created just that one question, a beautiful conversation that I think left everybody feeling really good and knowing that, you know, we're always doing the best we can. And babies tend to re-enlight something for people that maybe they've been disconnected from, but they are longing for that reconnection with their traditional ways through birthing and raising their children. So that is a little bit about our lunch. And then I think finally, I just wanted to share sort of the exciting work of where we're headed. We just received this grant from HRSA that's really about innovation in maternal child health. And so we, as the first slide alluded to, we are calling this our birthing sovereignty work. And I feel like this is just the beginning of where we want to go. With this grant, we are going to be able to, we've named some of our community partners, like I mentioned, Hummingbird Indigenous Family Services, as well as some other community partners who do really great work in maternal child health to develop an Indigenous birthing model that is primarily a group focused model. Many of you or some of you may have heard about the centering model that is out there as a group prenatal model that's been shown to be really effective at reducing things like instrumented deliveries like C-sections, and just it's a group model where you're sort of paired with people who are due about the same time you are. And instead of your individual meeting with a doctor or a midwife, and you do your usual every 4-week visit or the usual model of care, they actually move you into a group model. And so what we're wanting to do is create that group model, but to really create a new curriculum that's really grounded in Indigenous ways of knowing and being. And so we're really excited to partner with Hummingbird and those other community partners to develop this Indigenous focused centering model. And so we're in the very beginning stages of that. We have created a whole department around family services and have hired our first ever family services director who will help develop and create this model of care. And so we do expect that some people don't really want to be a part of a group. They just want to get the usual prenatal care. And so we would continue to have that option where people can kind of opt into usual care. But again, that includes the ability to also have more holistic care. You could have access to behavioral health, nutrition, pharmacy, but you continue kind of in that individual care model. On the other hand, we'll have a whole group of folks who are interested in really getting to know other people around them who are at the similar stage of pregnancy as them, who can create those bonds that I think are potentially long lasting. And one of the exciting parts of this is that instead of just ending it when they deliver their baby, we actually plan to continue it to 1 year postpartum. And so once people have delivered, we can start to integrate their children into care and conversation around parenting and some of the Indigenous ways of parenting, whether it be our feeding, our first foods, our traditional foods, and incorporating those into their babies' diets, thinking about maybe they've created these cradle boards, but now we can have a conversation about using them and have conversations about that when we're talking about reducing risk of SIDS and It's one thing to make a beautiful cradle board, which we do. We have cradle board making classes. But then what do you do after? How do you use it? How long do you use it? So we're really excited to be able to create a space for people to be able to talk about it, meet with traditional medicine practitioners, people from even dental or behavioral health, and really like, how do we incorporate a lot of this different aspects of care into a group of people who are getting their medical care, without the focus of it being so much just on their medical, but the bigger focus being on how do we really help you feel ready as a person, and what sort of people do you need around you to do this? I really think about how traditionally mamas always had their whole village around them. Everybody had a role and responsibility. And so when I think about this group, I really think about how do we equip not only the person who is birthing, but how do we equip their supports? So whether it be their partners or their aunties, their uncles, their grandmas, their grandpas who have come with their own history. And how do we equip all those people who are going to be touching this life, this growing life, into being the very healthiest version? And so I think that we're looking at all kinds of ways that we want to incorporate both conversation, but also who is going to be involved in coming to some of these groups, and how do we get everybody feeling ready to support this life, and this pregnant person's life that will forever change too. So I definitely, this is kind of an open concept because we are still in the early planning stages of it. I'll be excited to kind of come back maybe in a year and talk about where we've come with some of the work. But I wanted to share kind of that aspect of it. And then I think that may be all I have for now. So I'm definitely welcome for questions or things like that.
Awesome. Thank you so much, Dr. Love Thurman. I am watching the chat, so I do see a question from, well, actually first was Stephanie Vigil. Do you want to unmute yourselves and ask that question? I think it was related to the, do you have a specific policy for, oh, something's blocking my view. Tim Apprentice, TIM.
Yeah, hi, thank you so much for taking this question. I was just curious, I work for a hospital system as well, and we've been talking about how we can incorporate traditional healing and medicine, for our patients. And one of the questions that have come up is, around smudging or burning cedar, and how that would even work because of, the sprinkler system, sort of those logistics. And so we're at the very beginning of just exploring options and what other health systems have utilized to meet the needs of their patients. And so just curious if you had any policies or suggestions as we continue to explore this. Thank you.
Yes, yeah, thank you. Thank you for that question, because I think it's definitely something that we've heard a lot. And I'll even give you an example of when our CEO first started the job here at the health board. And that was only about 7 years ago. She was in her office kind of getting her stuff ready, and then she wanted to smudge. And so she started smudging, and then all of a sudden our facilities director ran into the room and was just like, stop, you can't do that. You can't do that. Like, you're gonna set off the sprinkler system. And so she looked up and she said, what sprinkler system? We don't have one. And I think that story kind of has continued to resonate with a lot of us, that sometimes there's a perceived fear that is not actually real. But I think in hospitals, of course, this is a real thing. And so I've worked alongside our local hospital too with fairly similar questions around how can we provide. I think too, it's a good question knowing that 90% of the people we care for are going to be in the hospital, oftentimes having their babies, and say they do want ceremony to be a part of that. How do we really protect the ceremony in that space. And so I know that in some hospital systems, they've worked with, it's usually like the chaplain service, to be able to sometimes create a space or a room where people can go. Because we're not the only folks who use like burning of medicine in a religious or ceremonial way. And so sometimes I think it's kind of asking those curious questions about how can we do this? If we can't do it in the room, can it be done somewhere else? I know that when I worked in the hospital, sometimes we would physically take people who could go outside, and then be able to provide like a smudging ceremony. And the way that I see traditional Indian medicine apprentices are the advocates or the liaisons to be able to get those needed or wanted ceremonies provided. And sometimes we're not able to overcome some of the policies that exist. And so we have to find if there are other creative ways, like maybe there's water ceremony, or there can be adaptations to some of our ceremonies that still maintain the integrity, but then also can fit in with some of the policies that we need to fit into. And so we actually have protocols for our apprentices. They are people who have an interest in traditional Indian medicine, but maybe, you know, they're not necessarily practitioners. They haven't spent their whole life or a big portion of their life really understanding our traditional ways or cultural ways, but they are folks who are really interested in maintaining the integrity. And so we do have certain protocols and training in place around smudging, around prayer, around talking circles. That's another form of practice that we do, and also for sweat lodge. And so we as an institution have created those policies or procedures in how to do that, and then how to train, so that we make sure that no one person ever takes off and does something that's really not appropriate. So that kind of is how we've been able to train the apprentices in a limited amount of ceremony that they can provide. I think the one other thing that we allow our apprentices to do is they will often, under the guidance of a practitioner, they can help gather medicines or make little bundles or certain teas. So I guess one example of that is I had a prenatal that I was seeing who was in her 3rd trimester. And I said, hey, you know, I think red raspberry leaf may be something that would be really great to add as a tea for you in this last trimester. And so our traditional medicine team was able to go collect red raspberry leaf and then put it into a tea that they could provide to this prenatal of mine. And so there is some of that happens where we can think about what are those plant medicines that are appropriate at various stages of pregnancy to introduce, to talk about, and to share. So I hope that kind of helped answer that question.
Yes, so I'm going back to a question from Alicia. So this was earlier in your presentation, and it's referring to if births are happening outside of IHS, are they happening largely at public/private hospitals and or birthing centers, or are they happening at tribal non-IHS hospitals?
Yeah, I think all of the above. I think that I don't have the exact numbers, but we know that they're happening in a variety of places. I know here in the Seattle area can speak to that. I think being in this urban area, we see most of them happening at private hospitals, and a little bit more so we're starting to hear from our community that there is a growing interest in birthing centers, and that's actually something that we're very interested in pursuing. Is I think our Native community is really thinking about how hospitals have really, in a lot of ways, become really unsafe for folks through racism, stigma. And so being able to create kind of community-based birthing centers is something that's really coming up in the birthing world. So that's something I'm having conversations with too, just locally. And I think it'd be important for you all to know where people are delivering and how they're delivering. I know that we're also hearing a lot of people who are wanting to have safe home births, and that's a conversation that we're having maybe with the introduction of midwives and even traditional birthing midwives. We've had some really great conversations around trying to create dialogue around all the different ways you can deliver and really making people feel informed in that decision. Because there are a lot of low risk births that, if that's what they want to do, we should be able to provide that conversation so that people can make informed decisions without feeling like they can't openly talk about it because of fear of what people may say or think.
Yes, thank you. So our next question from Lucretia is, she noted, this is wonderful. Is there some culturally indigenous model birth plan templates that are shared with local hospitals, providers, and OB nurses?
To my knowledge, there's not yet. I think that certainly, I'm really happy that we're never going to try to hold on to anything ourselves, so that I know that if we are able to create something that can be shared, we will broadly do that, especially with our partners in Indian country who are hoping to do similar work. I hope that answers your question. If it doesn't, please let me know.
And Candy, I do see your hand raised, but I'm gonna ask this question that came in right after Lucretia sent it from Jolinda. She noted, what barriers with being a FQHC have you found with barriers to prenatal care?
Yeah, Jolinda, that's a really great question. I think all FQHCs kind of have their own model of care. I think they do tend to have a lot of like primary care that does include prenatal care, but I can't speak for all FQHCs. What I do know is that in ours, we've really made it a priority that we are mainly comprised of family medicine physicians who can see all ages, including that person who walks in and is, in their second trimester, that we make sure that there's the right type of folks who can take care of them at any given time. And I guess I would encourage that for all our clinical sites, is to really try to be ready for anybody who walks in the door. We do take care of all people, but like I said, it's not really a barrier to getting culturally attuned care. And actually what I hear from a lot of people who are non-native is that they feel really welcomed in to the focus on traditional medicine that we offer everybody. So even if you're non-native, if you're going through a difficult time in your life, or you need some sort of traditional connection point, I don't think that we as Native people would have ever held that back from our community in general. And so we do try to provide that traditional service or that traditional care to anybody who's coming in. And I think we've seen nothing but good things from that, while also maintaining the integrity of our ways of being, if that makes sense. But so I would say, yeah, we don't have a lot of barriers that I can see by having that FQHC model. I think the one thing that I would share on that is that we have a Medicaid model called maternity support services, where you can bill for integrated services. Like if someone comes in and wants to see, or when someone comes in for prenatal care, that you can try to get behavioral health to see them for 15 minutes, a nurse to see them and provide like anticipatory guidance for 15 minutes. You could have them see the traditional medicine practitioner or other lactationist. And you try to get these little 15-minute increments, increase your Medicaid billable services. And that's something that we're also interested in doing. It doesn't really fit necessarily with the group model, but we're looking at it as a way to increase the revenue for being able to do all of those things that we're doing already. So if any of you are skilled in MSS, I would welcome you to reach out to me, because we're still trying to figure out how to do the kind of complicated system of that billing structure. So I guess that would be my only barrier that I see right now.
And Candy, did you have a question? I know she had her hand raised, but if not, I'll move on to Shahana had a question and she asked, are there resources available at a state level that we can access for prenatal care to be able to provide / share to the tribal communities? Gonna touch them.
I'm sorry. I think I was trying to see that as you were saying it, and then I didn't see it, and now I lost it. Can you say that again?
Yeah, no worries. So Shahana asked, are there resources available at a state level that we can access for prenatal care to be able to provide / share to the tribal communities?
Oh, okay. Gosh, not that I'm aware of. I think that there's still, and I think states are at different phases of this. Unfortunately, that's what I think is one of the issues across the country, is that there is so much variability in the way that we fund and prioritize maternal child health work. I think that it is in various parts of the country a growing priority. And so there may be certain states that you want to look for to kind of lead that work. I would say in Indian country, I am really enlightened by a lot of the work that's being done in Minnesota, in Washington, in Alaska, and in the Southwest, in the kind of New Mexico area. And I know you've got speakers of like my idols in these couple of days here. And so I would I think this is going to be your resource this couple of days, because I've seen the agenda and you've got really great people in there. So I would look to the work that's happening more locally and more in Indian country than probably at the state level at this point. And as we, like I said, as we grow and develop some of these things, I really hope that we'll be able to kind of share out too, because I would love to see more options for curriculums or ways of doing prenatal and postnatal care beyond just the usual, because the usual is not working. And I think that we all recognize that. So how do we hope to be able to share that out as we develop it.
Hi, this is Candy. Can you hear me now?
Yes.
Yes.
Hi, so yeah, Candy Cornelius from Wisconsin. I know we had chatted about the substance abuse program you have out in Washington. You guys are doing great things. I had wondered who takes the lead or organize the lunch. That sounds like an excellent idea. I oftentimes get moms together for childbirth education. They see each other, know each other, and they really do want to continue to connect. So I just wondered who's the lead on that, like staff-wise in the clinic.
Yeah, that's a great question. I mean, for the longest time, we have a department that's called Nutrition and Family Services, and it's comprised of nutritionists, our WIC and lactation office, and then a little bit of like our care coordination. So we sort of have a whole department that's called Nutrition and Family Services, and within that we have leaders who come together. But to get this recent prenatal group back, it was actually a combination of folks who all came together and met weekly to create kind of the who would do what, because I think at the time we didn't really have a point person who could take it all on. And you probably are in places where everybody's wearing a lot of hats. And so we just brought together all the important players, and then they divvied up roles and responsibilities. And so our nutrition part of it will usually do the food aspect, and sometimes they'll talk about some of the foods that people are eating that day, what kind of nutrients are in them, are there traditional foods that we're eating today, and what's the importance of that. We would have our WIC and lactation program director kind of do her part of, the lineup. And so we actually created like a week by week loose agenda of like things that we hope to cover and who would take point on those different things. And that included even pulling in our pediatrician who could do a little bit of teaching on safe sleep. It included WIC just to talk about WIC services. It included our community partners who will come and talk about the doulas and the importance of having doulas in your labor process. And so we just kind of like piecemealed it together. I'm excited that we actually just hired a family services director who starts next week. And it will actually then be her job to kind of put everything together, including adding the whole prenatal group model that's going to happen. And one thing I would say too, is that the weekly group is pretty loose. What we found is that most people just want, when they know what's happening, they just want to show up. They don't necessarily want to commit. And I think a lot of times we're asking people to like sign up and commit. And I think as a new parent, that feels impossible, right? Because you never know the status of your life at any given moment. And so we try to make it really open, really clear that it's a drop in, come for 5 minutes or stay for 2 hours. It's whatever works best for you. So trying to keep it as open as possible for new parents or expecting parents is important. And we have our traditional Indian medicine apprentices at that group as well. And so they opened it up with a prayer and a smudging. We hope in the future that we'll also be able to integrate some like crafting things into it, talking about maybe creating different like parts of your pregnancy bundle, so to speak. It could be making baby moccasins, which we've done before, or creating, we do have cradle board making class that, you know, you need a lot longer time to be able to do that. But we do hope to have some things that people can kind of pick up and do with their hands as we're having conversation too, in that cultural way. If I can just say one more thing, which you prompted for me, Candy, thank you, was that some of the future work that we're doing too involves our inpatient treatment center that we're going to be reopening in the next 2 years. And that's inpatient treatment for things like alcohol or opiate or other addictions. And part of our model is going to be having 10 of the 92 beds be designated for pregnant and parenting people. And so that would include a minimum of a 45-day treatment where people can bring their children with them to treatment. And for those who are pregnant, we would also plan to have this sort of form of a group for them so that they can engage with other parents on child rearing and all the things that they have to come together to help prepare for a healthy birth, but then also really include that extra layer of social work support at a very early stage so that we can really try to make sure that we're keeping our babies with our mamas when they are born. And so we look forward to including all people in prenatal groups, that whether you be someone who's suffering from addiction or mental health, or you're doing fine and you're maintaining work, that no matter where you come from, that we create spaces that feel so culturally grounded that everyone feels welcome. And so I think that's just something that we've been really thinking about is how to invite everybody into the circle in a good way.
Yes, thank you so much, Dr. Love Thurman. And let's see where we're at. So thank you for joining us today and sharing your work on the revitalization of Indigenous birthing families and communities, and highlighting the importance of culturally grounded approaches in Indigenous birthing practices. And thank you all for your kind words for our speakers throughout the session today. So this does conclude our last session of the day. And I want to express my gratitude for all the speakers that took the time to join today's discussions. We heard from our CDC project partners to learn more about the broader landscape of MMRCs and the work that is being done in tribal maternal health initiatives. And then we went into our MMRC panel, which was moderated by Dr. Jim, and learned more about how MMRCs can work to improve maternal health outcomes in Indian country. And later this afternoon, we got to hear from the Northwest Portland Area Indian Health Board with the Remembered Past Project. Let's see. and learning more about the importance of affirming language and practices and how we can work towards incorporating more gender affirming neutral relationship terms with Itai and Jericho. And I'm very grateful that they were able to join us. And we ended today's session with Dr. Socia Love Thurman on the revitalization of Indigenous birthing families and communities. So it's been a great day one of our institute, and I also want to express my gratitude for all of you taking the time to join us in this space. I know long Zoom calls can be tiring on the eyes, so I hope that everyone was able to get a break when they can. And it's just really special to come together in this space, and from joining us from different parts of the countries and communities and tribal nations, and coming from different backgrounds, and just understanding that the work that we're doing is very important. And as we learn, our collective efforts really can create some amazing things. And the purpose of this institute and why we wanted to develop something like this was really to just create a space to share knowledge and solutions to advance and improve health and well-being for our Native birthing people, families, and communities, but also to create new partnerships or collaborations. And I saw a lot of people connecting throughout the day on the chat. And I know with that, we're meeting our goals, and we have lots of exciting sessions for tomorrow. We'll have Nicole Gonzalez with the Changing Woman Initiative. She'll be sharing more on ancestral innovations at the crossroads of providing maternal health care, and Rhonda with the Center for Indigenous Midwifery. And she'll share more about midwifery work in Indian country. And then later in the Institute, we'll end with Cami Goldhammer to speak more about revitalizing culture through breast and chest feeding. And we'll end tomorrow's Institute with Lisa Martin with the Family Spirit Program. So lots of exciting things happening tomorrow and also today. And just want to maybe open this space for anyone who wants to share reflections or comments or questions. I'm happy to turn it over to all of you. And I can answer some frequently FAQs, so everyone will have access to the recordings and slides, and also the presenter's contact information or bios, so that will be included in a document that everyone will have access to. And I'll stop recording.